Hello everyone, this is Tom, a member of the patient support team here at Optimale.co.uk, and today I'm joined by Alastair, the co-founder and co-director of Optimale, to talk about the effects of exogenous testosterone replacement therapy on estrogen levels in men. We start by talking about the process of aromatization, whereby testosterone is converted into estrogen by the enzyme aromatase, the associated benefits and drawbacks of this process, and then we move on to discuss how an excess of estrogen can be addressed if needed, be it through pharmaceutical intervention like aromatase inhibitors, but also other interventions like alterations to the treatment protocol, correction of other hormonal deficiencies, and supplementation with certain vitamins and minerals that alter the metabolism and excretion pathways of estrogen. However, before we get into this, we do need to provide the disclaimer that neither myself nor Alastair are medical doctors, so nothing we say today should be construed as direct medical advice or instruction. So, without further ado, let's get straight to the video.
So, Tom, what is estrogen and why do men on TRT in particular have to be concerned with it or know about it? I guess is a better way of saying.
So, like testosterone, estrogen is a steroid hormone that's primarily known for its role within the development and maintenance of secondary female sex characteristics. And because of that, historically, it's been viewed primarily as a female hormone and of no importance to men, but we know that that isn't true. It's an extremely important hormone for men. It has numerous benefits for men that we'll come on to later. And we actually produce it from our testosterone, what we're taking for TRT. So, in the vast majority of your tissue throughout your body, you have an enzyme called aromatase, and this actually catalyzes the conversion of androgens into estrogens. So it converts testosterone into estradiol, which is primarily what we test in a blood test. But it's also capable of converting androstenedione, which is the precursor to testosterone, into a different estrogen called estrone. And this is happening in essentially every tissue throughout your body. When testosterone is produced endogenously, in the testes, it enters the bloodstream and it travels to target tissues, and it's converted into estrogen in what we call a paracrine manner. So it is essentially the estrogen that's converted from testosterone is produced and used in the tissue of origin without ever essentially having to enter the blood to exert its action. Whereas testosterone, because it's an endocrine hormone produced in the testes, it actually has to enter the blood to travel to the target tissue to exert its action. So because when we take exogenous testosterone for TRT, we're increasing our serum levels significantly of testosterone, it's normal and to be expected that we're going to see a accompanying increase in estrogen simply because you've now got more of the substrate for aromatase, you've got more of the precursor for estradiol. Mm-hmm. So it's perfectly normal to see an increase in estradiol and TRT. And likewise, a lot of people or a lot of men who find that they have low testosterone will also see that they have low serum estradiol on a blood test. And it's for the exact same reason that when you're low in testosterone, you no longer have adequate substrate for aromatase to convert into estrogen. So the two rise and fall together. And for the most part on TRT, this is good, this is desirable, and it's exactly what you want. Estrogen's important for sex drive, bone health. It has various forms of, it exerts various mechanisms of neuroprotection within the central nervous system. It's cardioprotective, mm-hmm. It increases HDL, and it generally improves lipid profiles. It's extremely important for erectile function, actually. Estrogen is actually... the estrogen receptor is a transcription factor for the expression of an enzyme called endothelial nitric oxide synthase, which is what most people know the role of nitric oxide in an erectile function. Well, estrogen increases the production of one of the enzymes that actually produces nitric oxide. So it's really important for erectile function, general blood flow, vasodilation, things like that.
Yeah.
And then, I mean, we could go on and on about the benefits. I mean, it's also involved in growth hormone secretion and downstream IGF-1 production. So it's really important.
I didn't realize that. That's interesting.
Yeah, no, it's a primary driver of growth hormone secretion from the pituitary. Yeah. So yeah, it has a ton of different benefits. But however, like all hormones, you can have too much and it can be problematic. And when serum estradiol does increase disproportionately in relation to testosterone, and we'll come on to some of the causes of that later, a lot of men will report that they start to experience water retention, and this is partly regulated by estrogen's ability to stimulate the renin, angiotensin, aldosterone system, which is it's the primary system by which your body regulates salt retention. So through stimulation of that pathway, estrogen can actually increase the amount of salt that your body retains, which is why sometimes people can get the just a bit watery and a bit puffy and have a lot of peripheral edema.
Well, it's also why kind of classic bodybuilder or someone who's taking a lot of testosterone, they get very bloated, moon face with a really puffy face.
Yeah, the Michelin, just full on Michelin man.
Yeah, and I mean, some men, even men on TRT who aren't even on that much testosterone, we see them getting some water retention sometimes for whatever reason, and you can often tell by the socks. Obviously, around the ankles, you get a bit of pooling of that kind of water retention. So occasionally, that's something to look out for when you're on TRT, definitely.
Yeah, exactly. So you've got water retention. Some men with elevated estrogen will report mood disturbances. So estrogen actually is a primary driver of serotonin production, and serotonin, due to mainly because of big pharma, serotonin acquired the reputation as kind of the happy hormone. Everyone who's depressed just has a deficiency of serotonin and will pop you on your SSRI and you'll be all good. But that's not actually the case. There's actually quite a lot of evidence to suggest that people with depression have too much serotonin, not too little. And
really,
and when people hear that, they say, okay, why do SSRIs work? But quite a lot of the SSRIs, sertraline, they actually increase the local production of neurosteroids like pregnenolone, progesterone, allopregnanolone. So sertraline specifically is shown to increase the activity of an enzyme called 3-alpha hydroxysteroid dehydrogenase, which is what converts 5-alpha dihydroprogesterone into allopregnanolone. And allopregnanolone is the most potent modulator of positive allosteric modulator of the GABA-A receptor that our body produces. And for those who don't know what that means, essentially, it makes the GABA receptors essentially more sensitive to GABA, so it's increasing GABAergic transmission. GABA is it's basically the body's primary system of inhibition. It's very calming, it's very soothing. For people that are familiar or have ever taken drugs like benzodiazepine or Valium and things like that, they exert their action through increasing GABAergic transmission. So it's a bit of a tangent, but SSRIs are shown to increase that system, and that's entirely independent of serotonin. But to get back on topic, estrogen can increase serotonin significantly, and serotonin that can lead to a downstream increase in prolactin, and basically they can lead to a suppression of dopamine, and dopamine's the kind of reward hormone. It's the motivation hormone. It's what makes a man wants to go out there and achieve and be productive. So that was a convoluted way of saying that elevated estrogen can lead to mood disorders primarily through suppression of dopamine. But it's
interesting to know the kind of the actual mechanism of how that acts on them. And it's why how estrogen can actually have a negative impact on it.
Yeah, absolutely. And it's why not always, but a lot of the time you'll see prolactin following estrogen on a blood test. So if a man's got above range serum estrogen, generally speaking, their prolactin's going to be trending towards the top of the range, sometimes above. And sometimes
we see that a lot.
Yeah, exactly. Sometimes people will just Google elevated prolactin and they'll see pituitary tumor, prolactinoma, and they'll suddenly get really worried. But for the most part, it's in men on TRT, at least anyway, it's primarily tied to your systemic estrogenic load, and we'll come on to how to address that in a moment. So some men report gynecomastia, so kind of glandular breast tissue growth, which no man really wants to be walking around with a pair of double D's. Not ideal. Some men report erectile dysfunction and actually a reduced sex drive again when it goes too high, and this is because again dopaminergic transmission is heavily involved in the mental stimulation and the mental side of sexual desire. So again, when you're suppressing that pathway, you can reduce libido. And with erectile dysfunction, too much estrogen can actually promote vascular leakage. So essentially, there's just
you need a balance, don't you? And if it's either way, then you are not able to maintain an erection very well.
Yeah, exactly.
Plus, if you've got reduced sex drive, you're not going to be able to maintain an erection as effectively anyway.
Yeah, exactly. Yeah. And then the other two things is that we see is lethargy, so just feeling a bit tired and a bit fatigued and drained. And then quite a lot of men will report anxiety too. I mean, estrogen's heavily involved in the adrenal axis too. It can promote ACTH release, and it can actually stimulate the output of certain steroids like cortisol from the adrenal glands, independent of ACTH production. So again, these are quite hyper-specific, and I'm not saying that everyone with high estrogen is suffering from all these different things, but they're just
generalized. Well, I mean, anxiety, I think we see all of those symptoms daily in different men,
Yeah.
Some if estrogen goes high, a lot of men will report lethargy, anxiety, water retention, low mood, gynecomastia if it's, really high or if they're prone to it. So I think, I think it's all relevant.
Yeah, exactly. Because I think, because I think more isn't always better. Estrogen does have a lot of positive effects that are essentially significant. They make up a significant proportion of the benefits that come from exogenous testosterone use itself. But more isn't always better. And if it was, we'd all be using a gram of testosterone per week or 5 grams of DHEA per day. But we don't do that because you can have too much of a hormone. I like to think of them, they have kind of a bell-shaped curve. So if you have too much or too little, you're going to have negative effects, but you want to be kind of somewhere in the middle. Some people call that a sweet spot. I don't think there was a long time where there was a notion held in the TRT community that you had to have your estradiol held within the it was mainly in America, so it was 20 to 30 picogram per milliliter. I think it comes out to about 80 to 120 in picomole per liter, which is what we use over here. But yeah, I don't think it has a specific sweet spot like that. But you can definitely have too much estrogen, and a lot of people argue that that's not the case, and estrogen's never a problem. And
I can't understand that at all. If you see people with high estrogen levels, it doesn't make any sense. It literally makes no sense to say that you can't have estrogen being too high. Well, I could understand it if they were saying, well, if you reduce your testosterone level enough, then you should have the correct estrogen dose. But then, some men, for whatever reason, which I'm sure we'll go into, just convert a lot more testosterone into estrogen, and they can't feel good with their testosterone level being low enough to maintain a low estrogen or an optimal estrogen.
What a lot of people don't understand is it's not always the absolute amount of estrogen that's the problem per se. It's more so the ratio of androgen to estrogen. So if you're just trying to decrease your dose to fix estrogen related issues, if your testosterone and estrogen's here and you reduce your testosterone to here, your estrogen's just, they go up and down together in unison. That's not to say that, if you're running at 60, 70 nanomole per liter, then obviously you're going to have high estrogen. It's unreasonable to expect to be that high testosterone wise, and then, to be sat down at 80 picomole per liter estrogen. But generally speaking, if you've got a reasonable amount of estrogen and testosterone, you're somewhere, like 28 to 32, top end of the range, reasonable, but well within normal physiological parameters, and your estrogen sitting at 200, realistically, the ratio is going to stay the same. So all that's going to happen if you reduce your dose to address that is you drop down to 20, 22 picomole per liter estrogen, and your estradiol, your testosterone, and your estradiol is still going to be sat at 150, 160, which for some men might not be high, but when you consider the actual ratio there of androgen to estrogen, it's just not favorable, and it's unlikely to produce symptomatic resolution.
Yeah, absolutely. And I mean, there are quite a few different ways that you can try and reduce that estrogen. I think obviously the main ones that we look at is in injection frequency. So you increase the number of injections per week, but you're splitting up the dosage, which is meant to lead to reduced spikes in estrogen levels because you're not getting the same peak of testosterone levels. Sometimes that works quite effectively, but a lot of the time, if estrogen's really quite high ratio wise to the testosterone that they've got there already, then you're really going to struggle. Unless, of course, you're testing them in a massive trough and they only had an injection, I don't know, 7 days ago, and they had a massive injection of sustanon or whatever, which we don't really do anymore. So, I mean, that's one way, and it can work for some guys, but a lot of guys doesn't work very well. Obviously, reducing the dose, sometimes in combination with an increase in injection frequency. And then I think the most obvious one for me is kind of reducing body fat. Obviously, that's much easier said than done for a lot of guys. The testosterone helps. I was talking to a guy just yesterday, actually, he's been losing like a kilo a week very easily by doing fasted cardio, and now he's on the TRT. It's not that the testosterone itself is necessarily burning lots of fat, although it does have an impact on that. You'll probably know more than I do about how much of an impact, but I believe it does, from what I've seen, it does have an impact. But it's more actually the ability to do fasted cardio and do exercise and have the motivation to do things, plus muscle building, which increases base metabolic rate. All of those things do seem to have a good combination and affect how easily you can lose that body fat.
Yeah, exactly.
So I mean, obviously, I think you're going to go on to this. The reason that reducing body fat has an impact is primarily because you've got more aromatase expressed in adipose fat cells. So if you're reducing the number of those, then you're actually reducing how much aromatase there is, which means there's less conversion of testosterone into estrogen.
Yeah, absolutely. I mean that's essentially the main thing. You're just reducing the absolute level of aromatase itself. You have less of the enzyme. So if you have less of the enzyme, you're going to have less conversion to testosterone to estrogen. However, fat cells are also capable of producing numerous. Fat cells are considered endocrine organs in their own right now because they produce numerous different types of hormones. They're a very large producer of what we call inflammatory cytokines. And essentially, if you've got elevated levels of body fat, you're going to be in a chronic low level state of inflammation, which itself directly induces the expression of aromatase. Any sort of inflammatory response generally induces aromatase expression because estrogen is very important for the early stages of tissue regeneration and repair. And essentially, inflammation is just a sign of dead or dying cells that need to be cleared up, and that can be your own cells, or it could be a pathogen that needs to be cleared up. But yeah, no. So you do have the absolute an increase in the absolute amount of aromatase itself, but you also have the fat cells producing inflammatory cytokines, which then travel throughout the body and lead to upregulation of the expression of aromatase in cells that are independent of fat cells or adipose tissues. So I don't think we need to go into too much detail about the benefits of losing body fat and getting down to a reasonable weight, because everyone
should know that by now.
Yeah, exactly. So yeah, as far as other things that you can do, reducing stress is a really big one. Everyone knows stress is bad for you. Everyone thinks they know what stress is when you've got a large amount of demand placed on you from work, or you've got a bad home life, or it could be physiological. You could be murdering yourself at the gym and not eating enough or not recovering, or all these different things. Cortisol is the primary the primary steroid hormone of the body stress systems, the sympathetic nervous system. So if you're in a chronically stressed out state, your cortisol is going to be elevated. Cortisol exerts its action by binding to the glucocorticoid receptor, and the glucocorticoid receptor is actually a transcription factor for the gene that encodes aromatase. So cortisol or cortisol, when it agonizes the glucocorticoid receptor, actually again leads to increase or upregulation of aromatase expression. So if you're chronically stressed, again, you're going to be producing more and more and more aromatase, and
sounds like a vicious circle of
exactly, yeah,
because production.
Especially if that said estrogen then goes on to cause a significant degree of anxiety or other different problems, it can definitely it can definitely lead to issues. So they're kind of like the common ones. Some lesser known causes of elevated estrogen and or avenues that you can investigate are liver function's a really big one. So if people don't know, the liver is the primary site of estrogen detoxification. The liver has numerous different types of enzymes that conjugate estrogen. So they attach different types of molecules onto the estrogen, which essentially prepare them for excretion. So you've got they've got really long names, and I struggle to get them out. They've got glucuronol transferase, which is an enzyme that attaches a glucuronic acid group to estrogen. And then you've got estrogen sulfotransferase, which attaches a sulfate group to estrogen. Now, what this does is steroids are lipids. They're essentially fat molecules because they're all derived from the structure of cholesterol. The cell itself is a oily lipid environment. It's lipophilic. It attracts fatty molecules, whereas the blood is primarily plasma. It repels. If you think of oil sat on top of water, they repel each other. It's kind of the same with the blood, which is a water-based medium, and the cell, which is a lipid-based environment. So naturally, steroid hormones are attracted inside the cell, and they want to reside there. When you attach a glucuronic acid group or a sulfate group, they then become water-soluble, and they're forced out into the serum. So the liver is a primary site of that. It's the main place which estrogen detoxification. It's called phase 2 detoxification occurs. So if you've got impaired liver function, could be fatty liver, could be cirrhosis, you could be drinking alcohol every weekend, you're going to have some degree of an impairment of that system. So the amount of estrogen at which you're excreting is going down entirely independent of the amount of estrogen that you're producing through aromatase. So you might have a normal degree of estrogen production, but if you've got an impaired liver and it's not being removed from the body and the throughput is impaired, it can still show up as elevated estrogen and produce all of the associated symptoms. And in a situation like that, an aromatase inhibitor might help, but it doesn't really address the actual cause of elevated estrogen.
Does it cause an actual build-up in estrogen then?
Yeah, exactly. It's not.
You basically can't excrete it, so it doesn't matter. You're continually producing, even if it's a smaller amount.
Yeah, exactly, because it's no longer being conjugated for excretion. So, and I mean, back onto the inflammation quickly. Inflammation. So you've got the two glucuronol transferase and estrogen sulfatase, which attach those two glucuronic acid and sulfate groups respectively to prepare estrogen for excretion. You actually have two different enzymes, one called beta-glucuronidase and another called estrogen sulfatase, and they do the opposite. They hydrolyze the bonds that attach the respective glucuronic acid and sulfate groups to the estrogen, and they remove them. So they essentially reactivate conjugated estrogens that are inactive, because when an estrogen is conjugated and it's got one of those two groups attached to it, its ability to bind to and agonize the estrogen receptor is significantly decreased. So you can consider it essentially inactive. It's similar to how when testosterone's bind to SHBG, it's there, it's in the body, but it can't really exert its action as a hormone. It's the same with estrogen when it's conjugated. So inflammation or tissue injury or bacterial infection or again fatty liver or all these other things, or various other different conditions, they increase the expression of the enzymes that essentially break down conjugated estrogens. So you not only is your ability to conjugate them and prepare them for excretion impaired, but you now also have more of the enzymes that break down the enzyme, the estrogen that is already conjugated back into their free, active, and essentially bioavailable forms that can then re-enter circulation, go back into the cell, agonize the estrogen receptor, and it's not a very good state all round.
Yeah, I bet. So I remember you've talked before about calcium D-Glucarate.
Yeah.
So how does that kind of fit into this?
Yeah, so calcium D-Glucarate, it's, I mean, like the name suggests, it's essentially a calcium molecule attached to a glucuronic acid group. So it can act as a substrate itself for beta-glucuronidase, and it also has there's also a downstream metabolite of calcium D-Glucarate that can also inhibit calcium beta-glucuronidase. So if you've got an if the cause of your estrogen excess is a low-level inflammation or some sort of liver issue, or you've just got an issue where you're not detoxifying it, and you've got elevated levels of beta-glucuronidase expression and activity, and your conjugated estrogens that should be excreted are now being broken down back into their free forms, you can take something like calcium D-Glucarate, and what that does is it will inhibit beta-glucuronidase, and it will restore the throughput of estrogen so that you now excrete it properly.
Interesting. So that's basically one way that potentially people could reduce their estrogen levels, particularly if they've got a liver issue, but also I imagine it still has an impact as kind of like a natural AI, aromatase inhibitor, for people who potentially don't want to use a pharmaceutical option.
Yeah, so it all depends on the problem. So if you've just got an absolute excess of aromatase due to if you're running too high or any other, you have maybe a genetic predisposition to express more aromatase, or again you've got elevated levels of stress, and if the problem is just overactivity of aromatase, it will still help calcium D-Glucarate, but it's not going to confer the same benefits to a person that it would if the problem was decreased throughput, you're not excreting it properly. So it can help in any situation, but realistically, the cases that you're going to consider, okay, this is going to really help, it would be with some sort of liver impairment. Yeah.
Sure. And just an interesting point on, you mentioned some people genetically have more predisposition to increase kind of aromatase activity. I actually did a DNA test. Who was it with? I can't remember who it was with now, but I'll put the link in the bio, whatever it's called, below, link in the description. It was amazing. Like, they had so many different things that they were looking at. I didn't know, things that they'd obviously worked out from people's DNA profiles. And one of them was actually aromatase production. And it was saying, you have a high aromatase production, therefore you're more likely to have increased estrogen levels, which is actually something that I have noticed. I need an AI. I can't manage my estrogen without that, regardless of injection frequency, dose, etc., unless I go on a really low dose where I basically have low testosterone again. So it's definitely a thing, and it was pretty clear from my DNA tests that it kind of fit with what my personal anecdotal experience of having high estrogen. So that was quite interesting. And I definitely wonder if that also plays into having low testosterone initially as well, potentially. I don't know, but I'm sure there's potentially a factor for a lot of guys, particularly if they're a bit overweight as well, and they're predisposed to higher aromatase levels. They therefore have a lot more estrogen, so they're losing some of their testosterone. Plus, they've got that suppression of their pituitary by the increased estrogen levels.
Yeah, it's definitely a possibility. I mean, I think like everything, genetics is always going to assume a significant role in any process or system at every level because it's so integral to our physiology. But so yeah, I think that would definitely be something to consider if you've got someone and they're in good shape, they're not overweight, they don't have any liver issues, their liver enzymes are normal, their ultrasound's normal, and they're just generally in good health overall. They don't have any other comorbidities, and they're still producing a ton of estrogen. Then it might be time to essentially to say is this genetic? Am I just genetically predisposed? And is this something I have to deal with? I'm always cautious about going down that route if someone asks why is my estrogen elevated, because I think there are so many avenues that you can pursue to decrease the absolute expression or activity of aromatase and increase the throughput that a lot of people won't need the aromatase inhibitor. So I get a bit cautious telling people it's genetic because there could be someone who
Oh yeah, I mean it was more an interesting.
I agree.
It was just interesting. I wouldn't suggest to patients that they go out and start getting tested because they think they have high estrogen.
No. I wasn't implying that either. I'm just saying I think genetics will assume a significant role for a small proportion of people who are in great health otherwise, and in that case, they might just need a pharmaceutical intervention. But there are still other areas to assess because I mean some of the things that we didn't touch on. I won't go into too much detail on these, but I mean hypothyroidism again will. Hypothyroidism is heavily associated with both overproduction of aromatase and liver impairment. So it's another thing to assess. Progesterone deficiency. So we're going to do some content on progesterone later down the line. But just as a quick overview, I mean, progesterone is one of the most potent anti-estrogenic hormones the body produces. It's a modulator of aromatase. So it doesn't inhibit aromatase, but it modulates it. And there's a key distinction there. It antagonizes the estrogen receptor. It decreases the expression of the estrogen receptor. It upregulates the activity of the enzymes that remove estrogen from the cell. So if you're a man and you're on T and you've got low progesterone, that could be something that you could consider investigating through the use of something like pregnenolone, which is a over-the-counter supplement that you can buy on Amazon and start with a low dose and start from there and yeah, correct deficiencies in other upstream anti-estrogenic hormones. But I mean, there are also some people report that they're poor converters to DHT. So for whatever reason, their 5-alpha reductase activity is low. And again, because DHT is such a potent anti-estrogenic hormone, if you're converting a ton of testosterone to estrogen, but your DHT is low, again, the kind of overall androgen to estrogen ratio might be a little bit off there. And it's another thing to consider.
Yeah, absolutely. I mean, it's amazing how all of these different hormones impact each other and have different effects. And, it's much more complicated than when you first get into this and you think, oh, testosterone converts into estrogen. That's it.
The body, I mean, the body's a system, like everything interacts with everything. If you get an increase in estrogen, you're going to be affecting your thyroid function, your adrenal activity, the production of other androgens, the production of neurosteroids, neurotransmitters, and then they all go on to all of those things go on to then cause their own downstream effects. And and
we see it, since when we first started this business, and we're helping men probably about 4 years ago now to get treatment for this. And, you could see from the blood test results, testosterone goes up, estrogen goes up, prolactin goes up, and then it's having an effect on TSH and FT4 as well.
Yeah, exactly. Yeah,
and you're like, oh, okay. So, these are all linked. That's not just like testosterone and estrogen having an impact on each other.
It's why modern healthcare is so messed up in so many ways, because you've got all these different subcategories of different doctors that specialize in different areas, and you've got one doctor that focuses on the liver, one on the kidneys, one on the nervous system and thyroid and general endocrinology and I mean. Specializing does help, but because these systems are so interwoven together, it's very hard to treat them in isolation. It's very, if you've got to a stage where you're going to a nephrologist and you've got, like stage 2 kidney failure, it's very unlikely that you're in perfect health and you've got great hormonal function and all these different things. But when you start treating them as isolated entities and you ignore system level biology, it doesn't really produce the best outcomes overall.
Well, I mean, if you even think about, I would say most of the doctors in the TRT space, including endocrinologists, most of them do not understand the hormones to this kind of level. I almost guarantee it. There's probably, some of the endocrinologists probably do understand the endocrine system to this level, but those are often the doctors who think that TRT is useless and doesn't work and not worth bothering with.
Yeah.
I mean, there aren't really any endocrinologists in the UK who are actually into TRT as like a thing, are there? That I can think of.
No, not really. I mean, their usual rebuttal is this is theoretical, mechanistic jargon that has no real clinical significance. That's their usual rebuttal. But then they proceed to tell a man with 9 nanomole per liter testosterone that they're perfectly fine, no problem, because they're within range, even though there are clear.
They've got clear
guidelines.
Symptoms.
Yeah, they've got clear symptoms, and there's also existing guidelines like the British Society for Sexual Medicine that states otherwise, and so it's just I don't know.
Yeah, well, we could do a whole thing on endocrinologists and what they've said.
Yeah, we probably will do at some point.
Yeah, it's not to say that some aren't good, but I think it's just a combination of factors has led them to kind of be a bit disillusioned by TRT and its effectiveness. And then they just see it as too much of like the risk reward is not there. So they, don't bother putting people on treatment. Or you really have to push them to get any sort of treatment.
Well, understandably, doctors are very big on first do no harm, which is should be the case. So say if you're an endocrinologist and your textbook or your guidelines that you adhere to say, start every man on 1 injection, 250 Sustanon every 3 weeks, and you've done that in 100 patients and they all come back saying I feel worse, you're going to take the mentality of this does more harm than good. If they're within the reference range, no matter how low, I'm not going to put them on because the people that I do put them on don't do well. But that's not.
And the hematocrit comes back at 58%.
Yeah, but that's not an inherent.
Okay.
Yeah, but that's not an inherent problem with testosterone. That's a problem with the way in which you're currently implementing it. And this is the problem with scientific research. You look at papers that show that, men. There are numerous papers that show that a man with testosterone levels within range, but no matter how low, don't do better when you put them on testosterone replacement therapy. So, but then you look at the papers and they're putting them on 50 milligram of androgel once a day or something like that. And it's like, I wouldn't expect someone to feel, if you're at 8 nanomole per liter, 9 nanomole per liter, and you get put on one sachet of androgel per day and you don't absorb it particularly well, I wouldn't expect you to feel well, but that doesn't mean that you don't need testosterone replacement therapy. It means that you don't need a suboptimal, ineffective treatment method. You need to go with someone that knows what they're doing. And the problem is you have so many studies like that, and all of a sudden you get to a point where there's 30, 40, 50 of these studies that are just poorly designed and don't reflect, they're not an accurate reflection of the way in which hormone replacement therapy is implemented. And now all these studies go into a clinical guideline, and then it's considered by the evidence-based medicine folks to say, look, this is the evidence that we don't need to give this man testosterone. Whereas you look at the studies and you can't, that doesn't say that at all.
I think there's also a kind of an effect where the medical community, if they, and this is the same with all communities and all people really, if they already have a bias towards something, say for example, their bias is that TRT is bad for your heart and increases your risk of cardiovascular issues, then there's a tendency for them to, if they find a study which actually isn't very good or has, it's got a small sample size or then the protocol they use is not very good or whatever, and that shows that there is some type of increased risk of cardiovascular disease, then they are much more likely to let that fly and kind of go, well, okay, this proves the point. This is exactly what we knew. So, whereas if it goes the other way and somebody has a study which finds that actually if it's done properly, it reduces risk of cardiovascular issues and reduces diabetes, etc., which there are actually studies showing, and they're quite good ones. I think the medical community need more, and they need better studies, and they need bigger studies to kind of prove it, because it goes against what they know as being true, or what they think is true.
No,
I think
agree.
that's just human nature, really.
It's just confirmation bias, yeah.
Absolutely, yeah. To put it more succinctly, it's confirmation bias.
Yeah. I mean that was a huge tangent for a discussion about estrogen, but it's worth talking about. You know, I mean, I'm sure we'll do top discussions about that in the future, but it's serious issues that and it's what leads to people like us doing what we do and having to set up entities that are independent of normal healthcare systems, because if you don't specialize in this area and you don't understand the nuance and the intricacies and the underlying physiology, then you can read those papers at face value and say, oh yeah, you know what, this isn't not worth doing this treatment, it's dangerous, doesn't work, doesn't make people feel better, all these different things. It increases the risk of blood clots because hematocrit goes up, which isn't true at all. The blood clots, sorry, hematocrit is true. But you know what I mean. It just it's why we do what we do. I think symptoms are always more important, or just as important as the absolute number on the blood test.
Absolutely, yeah.
So yeah, I mean, if someone wasn't, we're going to be throwing it. We have done, and we probably will again throw out a lot of numbers on a blood test as examples for the point we're putting across. But likewise, if someone's got a 170, 180 estradiol and they have no symptoms whatsoever and they feel good, then there isn't necessarily a problem there that you should be looking to directly address just to make a number on a piece of paper look better if the patient themselves feels good, you know?
Yeah, sure.
And I think one thing to talk about this here too is I don't see too many people talk about this, but in the UK we use what's called the standard ECLIA assay for estradiol. In America, they use what's called the ultrasensitive LCMS assay. The difference is with the standard assay, it has cross-reactivity for C-reactive protein, which is a marker of inflammation, and it's produced as a response to inflammation, essentially. So you have to be very careful when interpreting serum estradiol readings that are on the standard assay, because if someone's got some sort of chronic inflammation but and they're not having any symptoms of estrogen excess, but their serum estradiol comes back elevated, it could be that their actual level of circulating estradiol is perfectly normal, but because the test is picking up that cross-reactivity with CRP, you're getting a false positive result when the actual level of estrogen itself is perfectly fine. So again, I think that's another thing that people should be aware of if they're in the UK and they're using the standard assay. I see a lot of people dog on the standard assay and say that, oh, you should never use it, and you should only ever use the ultrasensitive. But I think that as long as you interpret it with the limitations of the assay itself in mind, as well as combining it with the symptomatology of the patient and not just using it as an absolute value that you make all your decisions off, I think it still has perfect utility. I don't think there's any reason to because I mean, theoretically, we as a clinic, we could spend a ton of money and get every single one of our samples shipped out to the US to a lab that could offer the ultrasensitive test, but we don't do that. And if it would lead to significantly improved outcomes for the patient, then we would do it. But it just doesn't, because when you interpret the standard assay with the limitations in mind, it's perfectly usable, and it's no. The ultrasensitive assay would be nice to use, but it's not needed at all.
Yeah, absolutely. Yeah, I mean, it's a difficult one in the UK. It's just much harder to get hold of that kind of testing, and the main labs that we use don't do it.
No, it's because I believe it's because the assay itself is patented, I believe, and I don't think any lab can just decide to start using it one day.
Yeah,
so it's not available.
There's certain options, things like saliva tests, which I need to look into in a bit more detail. I believe they are more sensitive than than the Lisa ones that we use. But again, it involves doing a completely separate test, paying 60 quid just for your estrogen.
Yeah, and again, if it's
Okay,
not going to, it's nice to know, but if it's not going to lead to improved clinical outcomes, if it's not going to change the way in which we treat you, if you've got symptoms of estrogen excess, you've got symptoms of estrogen excess, whether it doesn't matter if your standard test is 10, 20, 30% out. If you've got the symptoms, you've got the symptoms. If you don't have the symptoms, you don't have the symptoms. So it doesn't, I mean, realistically, it doesn't really change the way in which you approach treatment. So it's probably not something that people, but it's not something that people in the UK need to worry about, in my opinion.
Yeah. So, I mean, let's move on to pharmaceutical ways of reducing estrogen, because, I mean, there's some people, particularly in America, it seems to come from, they say you shouldn't ever use an aromatase inhibitor.
Yeah.
They're horrific. They're really bad for you. They're going to cause you to have low bone density. You're going to have bad joints. You're going to have problems with cardiovascular health. You're going to have all the issues that basically are associated with a low estrogen level.
Yeah.
In men. Clearly, it's not that simple. I mean,
no.
I've been taking exomestane for probably 3 years, I reckon. Low dose. My estrogen always comes back at a really good range. I've still got plenty of estrogen in my body. If anything, it's more likely to go high than it is to go low ever. So is that going to cause these issues that they are indicating if you've still got a good level of estrogen in your body?
So the answer is it's complicated. So
yeah.
So here's the main problem. There are little to no studies that investigate the long-term impact of using a low dose of an aromatase inhibitor to bring down an elevated level of estradiol back into the reference range in a man on exogenous testosterone. What we have with regards to the long-term safety profile is lots and lots of studies investigating the effects of very, very high doses of these drugs. 1 milligram of anastrozole per day, 25 milligram of exemestane per day, given to women with estrogen positive breast cancer. One of the kind of rebuttals that the anti-AI crowd point to is that, aromatase inhibitors are cancer drugs. Why would you ever want to use them? And that is somewhat true in that these drugs were designed to inhibit aromatase so that to remove estrogen from the body to treat estrogen positive breast cancer. But you can't then extrapolate that across. So one of the things that they do is they say, if we've got all these studies in women on 1 milligram of anastrozole per day, say, and they're all coming back with osteoporosis and their risk of dementia and neurodegenerative diseases and all these different very unpleasant pathologies are significantly increased on a big dose, then why would you want to slightly increase your risk of those diseases by taking a little dose? And you just can't extrapolate like that. It's not the way physiology works. If I was to infuse 10 liters of water into your veins right now, you would die very, very quickly. But that doesn't mean that drinking 4 liters of water a day causes a little bit of harm.
It's the same with testosterone, isn't it?
Exactly.
Oh, well, some people who abuse testosterone and end up with this issue, that issue, and the other issue. Therefore, we shouldn't be using TRT at all because a small amount of testosterone has the risk of causing certain conditions.
Yeah, exactly.
It's exactly the same false logic.
But they take those studies in high-dose breast cancer trials and they point to that and say, look, aromatase inhibitors are cardiotoxic, neurotoxic, they destroy your bone health, don't ever use them. And then they claim to be evidence-based and they say that they use generic, broad sweeping terms like the data shows and the science clearly indicates, when realistically, until we have a study long-term in men using a low dose of an aromatase inhibitor like exemestane to bring an elevated level of estrogen back within the reference range, nobody can say they're toxic, they do this, they do that, because the truth is we don't know. So you can't extrapolate across like that. And then the next rebuttal that when you present that to them, the next rebuttal they will usually say is, show me a study that shows benefits from reducing estrogen. They then say all of the studies that investigate the positive effects of testosterone replacement therapy on reduced cardiovascular disease, increased endothelial function, increased sexual function, protection against different types of neurodegenerative disease. None of those studies used an aromatase inhibitor. All of those men who took the testosterone in the studies will have experienced an elevated level of estrogen, but yet they still experienced and were documented as receiving benefits from testosterone replacement therapy. So even if there are no studies showing the harm of low doses of aromatase inhibitors, there's also no studies that support blocking aromatase in men. And again, I think it comes down to absence of evidence isn't evidence of absence. So again, there's also no long-term trial that compares two groups of men, one on high dose testosterone without an aromatase inhibitor, one on high dose testosterone with an aromatase inhibitor, a moderate dose, not too high. You track what happens to them 1 year, 5 year, 10 year, and then you compare the outcomes from those two groups. That study doesn't exist. So again, if that data doesn't exist and we don't really have much data at all in terms of investigating the long-term effects of elevated estrogen in men, all we can really go off is clinical practice and clinical experience. So if you've got hundreds or thousands of men coming to you saying, my serum estradiol is above range, I'm getting gynecomastia, I don't feel good, I'm carrying 5 kilograms of extra water, you can give them a very, very low dose of a steroidal aromatase inhibitor like exemestane. It gets rid of all of their symptoms. You track their lipids, you track their bone health, you do all these different things, and it just makes them feel better. And there are no other quantifiable, essentially, there are no indicators to suggest that it's harming their health. Then there is no scientific evidence to suggest that that is harmful or that's a problem or that it shouldn't be done. There just isn't.
Well, I mean, we've got hundreds of men like that, literally hundreds of men like that. And, I haven't seen anybody who's come back to us saying, oh, I just had an insufficiency fracture and it turns out I've got low bone density after being on TRT with exemestane. Hasn't happened. Touch wood. But, there's no indication that we're getting any of these problems. If it's well controlled, well monitored, if someone comes back and their estrogen has ended up becoming low, which is rare, then obviously something needs to be changed, monitor it, change it, make sure that it doesn't continue to be an issue. And people, I mean, going back to it basically comes down to, are you going to purely rely on the science? I'm a big proponent of science, but you have to be aware when the science is inadequate.
Exactly.
And there aren't enough studies to effectively measure what you're looking at. And if that's the case, then anecdotal evidence, if you've got loads of it and we see it day in, day out, it's, they're effective. They work extremely well. They improve people's symptoms a lot.
And the studies, exactly, and the studies they cite aren't specific to men on TRT with elevated estrogen using a low normal dose to bring an elevation back within the normal physiological reference range. That study doesn't exist. That doesn't mean that aromatase inhibitors don't cause harm. It doesn't mean that they don't have side effects. It means that we don't know. So if we have tons and tons of anecdotal reports showing that some men with elevated estradiol have symptoms that are essentially attenuated with the use of a low-dose aromatase inhibitor, and there are no other perceivable negative drawbacks to their health when they use that, there is currently no reason not to use them, and there is a lot of reason to use them. Like you said, if we were having tons of people come back and suddenly their DEXA shows that their bone mineral density is dropped by a third, or like suddenly just things like that, then we would obviously reassess our position. And likewise, if a long-term study that tracked the 10-year outcomes of men on AIs versus men not on AIs, and it was to show a lot of harmful things, then again, we would reassess that. But like right now, there is no evidence to suggest that these drugs are any of the cardiotoxic, neurotoxic, or whatever other blanket term that people want to throw on them. I think that
I mean, it's worth mentioning at this point that it, that as with all medicine, although I think sometimes this gets lost a little bit in current modern medicine, but you should be avoiding putting people on unnecessary medications
absolutely,
as much as possible. I'd like to think we do that at Optimale. We don't put people on an AI for no reason at all. And we also monitor, occasionally somebody will be put on when they start treatment because the doctor has identified that they are overweight. They've got a high estrogen level already on their blood test before they've started TRT, despite a low testosterone level, things like that. They may put them on an AI initially because you don't want somebody starting off and suddenly getting really high estrogen and then having to deal with that later on. But we monitor it, and if estrogen levels are then too low when they're on that AI, then we change it and make sure either remove it completely or it's reduced. It's and I think that's good medicine, really.
Oh yeah, absolutely. And like I said, we always do everything we can to address the underlying causation of elevated estradiol if possible, so that they don't need the aromatase inhibitor. I think one thing to highlight is one, like we said, if a man's got elevated estrogen on a blood test, as long as it's not absurd, as long as they're not pushing 300 picomole per liter, if they're not having any symptoms, then we don't treat a number on a piece of paper, So one, we're not throwing aromatase inhibitors at everyone just to make a number on a piece of paper look better. But two, I think I think we, like I said, we do try to so some people view testosterone replacement therapy as a kind of panacea of health. So sometimes they'll be on treatment for a year, all of their problems haven't gone away, they look at their estradiol, it's slightly above the range, and they kind of use that as a scapegoat to say, this is why I don't feel good on treatment, this is why I've got this issue, this is why I haven't got this issue. When in reality, they might have underlying deficiency, they might have hypothyroidism, they might have deficiencies of pregnenolone, progesterone, DHEA, they might have, some sort of underlying chronic infection, they might have adrenal issues. There are so many other factors that could be causing their problems that aren't actually related to their slightly elevated estrogen, but they just view TRT as, oh, if I don't feel perfect, it must be the estrogen because my testosterone levels are normal, that I'm on TRT. So let's just do that. I think that we always, yeah, I think that a lot of problems do get scapegoated on estrogen when it's actually a problem elsewhere. And like we always look to that, we'll always assess thyroid function and basically just make sure that, okay, it's not a comorbidity or something like, hereditary hematocrosis or all these different things that are actually causing them to feel good, and it's not the estrogen. We make sure that, okay, this person, they're on a sensible protocol, so they're not on, one injection a week or one injection every 2 weeks. Their free testosterone and their total testosterone are at a good level. They don't have any other comorbidities. They're in good health otherwise. Everything's great, but they've still got elevated estrogen and they've got symptoms of estrogen excess. And in a case like that, there's no reason not to use a low dose of exemestane if it gets rid of their symptoms. There's no evidence to support that that's harmful or that it shouldn't be done. And there are a lot of benefits to be gained for the small proportion of men who simply cannot control estrogen with lifestyle factors, and they don't have any other confounding variables that might be causing the symptoms that they're attributing to estrogen. It's confirmed that it is the estrogen causing the symptoms. Everything else is clear. You put them on a low dose of exemestane, they feel good. Like, there's no problem there, in my opinion, and I don't think there's any data to suggest that that's harmful or shouldn't be done.
No, absolutely. I think from my point of view, some of the stuff we've spoken about today, very interesting. There's quite a few things here that we could work on, particularly around the kind of modulators of aromatase that might be another route for people to take if they have a moderately raised estrogen or high estrogen symptoms and they're interested in trying that before an aromatase inhibitor.
Yeah,
so that's something that it's worth discussing more and having a think about, and how we can improve our practice as a clinic. But I don't think anyone else is doing that. That's not to say that we shouldn't do it. I'm just
no.
and you can move to daily injections of everything to try and reduce your estrogen level, but most people don't want to do that, to be honest. I certainly don't want to do that. And I from my experience of putting men on those kind of, well, not me personally, but from seeing doctors who have done it, it doesn't always solve the problem. And actually often what you end up with is somebody who doesn't actually feel very good because their testosterone level is not very high and estrogen still isn't that great.
Yeah,
they have low sex drive and low mood and everything. It's like, well, what's the point in being on treatment?
Yeah, exactly. And I think, with regards to moving to daily injections to reduce estrogen production, I mean, generally speaking, estrogen follows T in a somewhat linear fashion. So, like, you might reduce the number on the piece of paper by moving from 3 times a week to every day, but your average estradiol across the week is still going to be somewhat similar on 3 times a week, twice a week versus daily injections. So, it might look better on the piece of paper, but the actual circulating level of estradiol in the body across the week is somewhat the same. It's more so the fact that you're removing hormonal fluctuation that causes the benefits more so than reducing estradiol. But the problem is there's also no evidence that you can point to say that everyday injections work better than 3 times a week. There's I think a lot of people in the TRT community have this idea that more stable levels is always desirable no matter what. But obviously, like, they're right to a point in that if you're doing every 2 weeks or even once a week injections, you're going to be on such a hormonal roller coaster that you're going to run into problems. But your levels are going to be pretty steady on 3 days a week, and I don't think there's no literature you can point to show that the increased stability going from 3 days a week to daily injections, leads to any marked improvement. Yeah, exactly.
I think for rarely for some people, particularly potentially with the HCG side of things, daily injections for a small minority of people can have a difference. Whether it's placebo or not, I don't know. But I completely agree. I think every other day is more than enough for most. We're not injecting testosterone with no esters here.
Yeah.
If you were doing that, then it would make 100% sense to do it daily, if not twice a day, or 3 times a day. But we're not doing that. It has a fairly long ester on, half-life of 6, 7, 8 days. It doesn't mean that you get as much of a peak, basically. And I think we've covered that before.
The people that get the most benefit from daily injections are those with very, very low levels of SHBG. So, sometimes if someone comes in and they've got insulin resistance or something like that, or metabolic syndrome, that whole kind of package, sometimes they'll come in and they've got a 7, 8, 9 SHBG, and because SHBG is kind of like the buffer that not only transports testosterone around in the body, but it also, stops it from being excreted and conjugated, similar to the estrogen metabolism that we spoke about before. So if you've got low SHBG, daily injections definitely does have some utility. But I think that if you've got a reasonable level of SHBG, again, I don't think there's any data we can point to, either clinical or scientific, that suggests that there's going to be that there's going to be a benefit of daily injections versus every 3 day that outweighs the drawbacks and issues with adherence that comes with having to do an injection every single day, or maybe 2 injections every single day if you're using HCG2. And that's not to say that the people that advocate for those things are wrong, or it's just a difference of opinion, and I think that, like you said before,
they might be wrong. We just don't know enough to say who's right and who's wrong.
Exactly. Yeah. Like when there's not enough specific scientific literature, all you can really go off of is anecdotes. So and other people might have seen different things or experienced different things from you. So and when you can only go off clinical practice and anecdotes, people are always going to have different opinions. That
absolutely, yeah. The positives, and there's benefits and downsides to both of them, really, or all approaches, really. Well, up to a point.
Yeah, yeah.
Anyway, I mean, that's something we should discuss another time, actually, and go more into more detail, particularly around SHBG and the impact of that and different levels of that on how you should be dosing, that kind of thing.
Yeah, I think the only one other thing that I think we should touch on it with regards to the anti-AI crowd's rebuttal. I think they do have the one good point that I do think they have that's it's quite hard to argue against is that estrogen's a paracrine hormone. So estrogen is produced largely, especially in men on TRT who are no longer producing intratesticular testosterone. Estradiol is largely a paracrine hormone. It's not an endocrine hormone, which means that it's used and produced in its tissue of origin without ever having to actually enter the blood. So when you think of an endocrine hormone like testosterone, it's produced in a gland in the testes, it enters the blood, and then it travels to the tissue in the blood where it then exerts its action. Because estrogen is produced in the tissue where it acts itself and it's metabolized in that tissue, its effects are largely specific to that tissue, and what you're detecting in the blood is essentially what's leaking out of the tissue, rather than the actual kind of. So with testosterone, you can look at the serum level, and because it's an endocrine hormone, you can get a very, very good gauge of exactly what that person's gonadal status is. With estrogen, because what you're picking up is what's coming out of the tissue, there is some debate that theoretically, because each tissue is going to have different levels of aromatase expression and different levels of aromatase activity, you might take a low dose of an aromatase inhibitor and your serum estradiol is normal, but you could have a tissue somewhere in the body that doesn't have much aromatase activity and isn't really contributing much to the overall systemic kind of pool that's leaking out that you're picking up in the serum. And even a low dose of an AI could render that tissue completely devoid of estrogen. And I think that that is a somewhat valid, I think. And there are studies that show that there is a significant difference between the tissue level of, they take a tissue biopsy and they compare the amount of estrogen in the tissue compared to what is in serum. And there are a lot of studies that show that there is a significant difference. However, most of those studies are in postmenopausal women who have lost their ovarian progesterone production. And what they find is that, and the reason I specify that is because postmenopausal women have a much more similar endocrine system to men once the obviously they don't have testes and they don't have a ton of androgens floating around, but when their ovaries are shut down, it's much easier to compare across between postmenopausal women and men than it is with menstruating women and men. But when they lose their ovarian progesterone production, most of the studies that look at the difference between tissue estrogen and serum estrogen show that there's actually much more estrogen in the tissue than what would be expected from serum. So although there is the possibility that you're blocking estrogen in certain tissues and you don't know what you're blocking, most of the data shows that there's actually more estrogen in the tissue than what would be predicted from serum. So again, that's potentially not a very good rebuttal,
yeah, potentially it's something that needs more research, isn't it? But again, until we start seeing specific tissues having or displaying much lower levels of estrogen after using AIs,
yeah,
particularly
exactly.
if we're not getting people to that low level of estrogen where you'd potentially expect to see that.
Yeah, exactly. Yes. But no, I think that wraps that up nice. I think the take-home point should be that there are multiple ways that you can address estrogen excess without resorting to a pharmaceutical aromatase inhibitor. A lot of the time, the symptoms of estrogen excess might be a different underlying pathology, like another hormonal deficiency or just general life stress or all these things. You might have elevated estrogen and you don't have symptoms, in which case there's no need to fix it. But if you've corrected all other possible causes of your symptoms and it has been narrowed down to, okay, my estrogen is elevated in relation to my androgens, and I have a very poor androgen to estrogen ratio here. There is no data whatsoever specific to men on TRT that suggests that you shouldn't do that it's cardiotoxic, that it's neurotoxic, or anything like that. So yeah, I think when you interpret the patient's clinical context as a whole, and you're using an aromatase inhibitor in that context, I don't think there's any reason to be worried. And I think that I would be more concerned about, the long-term impacts of chronically unopposed estrogen versus
well, exactly.
versus
That's not good in itself, having that amount of water retention or, gynecomastia.
Yeah,
Nobody
exactly.
wants that.
Yeah.
All right. Well, anyway, that was really interesting, Tom. And hopefully we'll be back soon discussing some more topics.
Sounds good.
All right. Thanks a lot, and see you later, guys. Thanks for listening. And hopefully we'll be putting some more stuff out soon.
So that concludes today's video. We hope that you found it informative and also that it cleared up some of the confusion and misconceptions that can be found online regarding the topic of estrogen on TRT. As always, if you have any questions or topics that you'd like us to discuss in the future, please comment below or contact us directly at info@optimale.co.uk and we'll be more than happy to get back to you. Thank you for listening, and be sure to subscribe so you don't miss any of our future content.